Thanks so much, Rachel. And thanks for joining us. The first thing I want you to do is to stand up, okay? It's lifestyle medicine, it's group consultations. And then if you're sitting on your own or at the back, I also want you to come forwards because we're going to make this as interactive as possible. And we want you to understand that we are stronger together. And there'll be an opportunity for you to discuss things. Essentially, what you'll find is when you learn in groups, when you deliver care in groups, it's better. And we're going to go through the detail of that. Those people who are on your own, please squeeze down. Please come down, okay? People who are coming in, please come close, come close. Come down to the front. We've got a massive auditorium, but I have to say, I've delivered care in this size of group before, and it's amazing. So we're going to cover a lot of ground today. And as you've stretched your legs and wheeled your arms in the air, and finally sit down. Thank you so much. Wonderful. So, got all my contacts on there if you wish to. I'm going to find this very distracting that it's changing everything, but I'm all for accessibility. So if I need to be edited or something needs to be bleeped out, then hopefully this will manage it. So what we want you to be able to do by the end of the session is to understand what they are, physiotherapy group consultations, the benefits and challenges, and look at how care delivered this way with some really strong examples of how it works and how you can do it. You'll have heard directly from your peers, and you'll have experienced what it's like to be there. Now, please, before we get started, I want you to hook onto Mentimeter, either scan the code or put those numbers into the menti.com website, and we want to find out really what experience you've got of the groups. Just going to check that this is working.
And there should be 4 questions in the Mentimeter. So if it's not working, let us know.
It doesn't seem to be going forwards to the next question. You've already responded. Is somebody running the Menti in the back?
Oh, yeah, we've had a yes from here.
Just the first question. So we need to answer all of them, do we?
We'll give it 1 minute and then we're just going to do the old-fashioned up on your feet in a second. Pardon?
Oh, really?
Oh.
Okay, nice. So what we've got is 50-50. Half the people have done it before and half haven't. And then, how do you rate the idea? It's funny because it hasn't gone on to the second question on mine. Interesting. So a group consultation is delivering care in a group instead of one-to-one. So you do everything you would usually do, but you're doing it to more than one person. It can be done either at the beginning or after you've done the initial assessment. So it's been used for both. These are really good questions. So people are rating the idea reasonably highly. Most people are giving it 4 or 5. Now we know what it is.
Or they think they know what it is.
Well, we'll check again at the end. Okay? And then when we go to the next one, how do you think the patients rate the idea of group consultations? Not sure why it's not asking me. Oh, it is. It's catching up now. It's catching up. Very laggy. Yes. So patients have mixed views about it, so I think that's fair, absolutely fair. Again, we've got some decent numbers. And then, finally, what do you see of the key benefits? What's good about it? You can choose multiple options for this one. Looks like mostly people have answered 1. Reduce waiting times, prevent the need for repetition, and saving clinical time. Okay. I like the fact that nobody said there's no benefits. Thank you so much. So, let's go back in history, because this is not a new model of care. This is Joseph Pratt, and I'm very grateful to Beth Freites, who's the president of the American College of Lifestyle Medicine, for flagging the existence of this chap. Joseph Hershey Pratt. In 1905, he delivered the first group consultations, and he called it the class method. And he took poor people who had TB, who couldn't afford to go into hospital, and he treated them in groups. and their outcomes were actually as good as any intervention at the time, and it showed the benefits of seeing people in groups. He then, it spread into diabetes, into chronic heart disease. He moved to the Boston dispensary. He started group psychotherapy, not widely credited for that, but essentially in 1955, they then held a great big conference, a celebration of his life at Massachusetts General Hospital, and it was published in the New England Journal, which is their local rag, and it was everywhere. It had been a great success. But then these old print publications kind of got lost, and electronically they weren't scanned in until about a decade ago, and they're not as easy to search because they're not indexed on PubMed in the same way. So the key is, we forgot, but this goes a long way back. And the key is, you can deliver what great healthcare looks like in a group. Great healthcare, Don Berwick's view of this would be that it delivers great outcomes, it gives you patient satisfaction, and it's cost effective. Then that was built on in 2015 to say that maybe the clinicians should be happy as well, and there should be a joy of delivering care. And then the final element, which was included in our patient co-authored publication 3 years ago now, was the idea that we can deliver great education as well. So that's education not just for the patients, but education for the healthcare team. So that's what you can deliver, what all aspects of great healthcare look like. So if you're doing any study, and we talked in the last session about how you should measure your service so you can persuade people to fund it, if you do it mapped to that quintuple aim, then you'll have all the data you want to persuade anybody. There's lots of published evidence, and a lot of the greatest evidence is actually in antenatal care, where there's numerous large cluster randomized trials which show that it's better, you get better outcomes, more knowledge, more satisfaction, lower rates of low birth weight, lower rates of hypertension in pregnancy. Pre-pandemic, 85% of the 2-year checks were being done in groups in Hertfordshire. Kids' bowel and bladder surface. So here's an example. This was an initial assessment where they were seeing people who were new patients, the child and their 2 parents, and essentially they implemented this service and it got rid of a 3-month waiting list overnight. So they actually had 50 people in a room, and then that scaled, so you ended up with 37 families in the same session. So that delivered great satisfaction, great care, and wiped out waiting lists immediately. Lots of data in diabetes where it shows that you can get better information, and flag particularly David Unwin's data, which was published last year, showing 50% remission in type 2 diabetes. Very good for kidneys. And then the elderly, we obviously tend to see people when they have a particular problem. They're presented with shoulder pain or knee pain, but actually, we're always trying to think of the whole patient. I think as that last session showed very nicely, if we can encourage them and move the curve towards them doing some regular aerobic and strengthening exercise and doing balance exercise, they will be better off long term. And here, we saw in this type of group, you could treat people with multimorbidity. It didn't need to be just one problem, one localized pain. The examples you'll see today are focused on that, but I want you to recognize the benefits for other parts of the person, treating the whole person. So the idea, here's your definition. It's seeing people in a supportive environment and delivering, with the shared medical appointment model, for example, a serial observed consultation, but there are other models that you can use. The idea is they get all the care that they would want, but instead of being time constrained and having perhaps a 15-minute or 20-minute appointment, you end up with everybody in the space for 90 minutes, so they get more care, more questions, more answers. You can do that virtually, and you can do it one-to-one. So I'm delighted now to hand over to your peers, really, who are going to share their experience in this setting. And we're going to start off with John Paul, who's now working, I don't know, I had mixed feelings about this. He's actually working in occupational therapy at the moment, but he's a physiotherapist, proudly.
Occupational health.
Occupational health, sorry, not occupational therapy, occupational health. And he's a physiotherapist with a particular interest in group consultations. So over to you.
Thank you.
We're going to do a Q&A, of course, at the end of the presentations.
Afternoon, everyone. Thank you for coming along. So my name's John Paul Gowland, and I'm going to be talking to you for the next few minutes about how we introduced group consultation into our MSK service up in Gateshead, where I work, but specifically how we manage patients with atraumatic shoulder pain. So we need to set the scene. We need to go back in time to 2019. So pre-pandemic, early pandemic, it was February, I think, and I was working as a clinical specialist in the Tyneside Integrated MSK Service, or TIMS for short. And TIMS looks after the population of Newcastle and Gateshead, about 500,000 people. And like most of the NHS, we were seeing an increase in demand on our services. So we said as a team, it was time to rethink how we deliver our care. And this is where we were introduced to the group consultation team. As one of the pathway leads, I was asked to see how we could incorporate group consultation. And if you shut your ears, Alison, for a second, I was a little bit dubious about how we would be able to do that. But I went off and had a look. My light bulb moment was in a busy MSK clinic, second opinion clinic, patients every 30 minutes, and I must have seen about 6 to 8 patients with atraumatic shoulder pain. I'd given them the same advice, the same education, answered the same questions, pretty similar rehabilitation programs, and by the end of it I was beat. I thought, why don't we do this in a group consultation format? And thus the idea was born. We need to now jump forward in time, because we all know what happened at the end of 2019, the pandemic hit, services were stopped, but we picked the group consultation back up at the end of 2020, early 2021. And it was virtual, because we had restraints about who we could bring into hospital sites. So we started with a virtual group consult. We invited patients with atraumatic shoulder pain to attend a 90-minute first appointment and 2 hour-long appointments for follow-up over a 3-month period. But how did we find our patients? Well, we used our referrals from our GP colleagues, our secondary care colleagues, but we also used our triage process to help us identify patients with atraumatic shoulder pain. So we wanted patients without history of trauma. You know, it wasn't the traumatic shoulder pain group consult. We wanted patients with no stiffness or instability symptoms, no neck pain or altered sensation, and no one with any history of red flags. We didn't want to manage those patients in this way. But we had a triage tool available to us that allowed us to really get all the information we needed to help kind of funnel patients into these sessions. So what did we do next? Let's just look at the patient journey. So patients have been identified by the triage tool or the referrals. And once they were identified, they were contacted by the admin team. They were sent an information video and leaflet about the benefits of group consultation, what it was, but importantly, what the alternative care they could receive. We weren't forcing people into these sessions. Baseline information was measured prior to the appointments, just to help us with our service evaluation. Session 1 was led by our facilitator, which was Mark, one of my TI colleagues. And here Mark would explain how teams worked, because we can all remember back to then, can't we, when we didn't know how to mute, and I think we had a parrot that was particularly noisy in the background in one session. But he talked people through it, he introduced the session, explained what was going to happen. He invited the patients then to tell us about their problem. I should note, I was hidden off camera. In the first few sessions, I sat next to Mark, but as we progressed and felt more confident, I'd be sat in my base site, which was the other side of Gateshead. Mark would then ask for patients' experiences about what they were there for, so their history of presenting complaint, really, I suppose. And on average, it was 2 to 3 minutes of, I've got a hurty shoulder, I don't know why, help me out. Mark would then check everyone's range of motion, get everyone up and about and moving. He would then, through a series of preset questions that we've devised together, explore the patient's thoughts, expectations and beliefs. How long do you think this is going to take to get better? Are you worried about anything about your shoulder pain? And anyone in the room that's managed patients with shoulder pain, it was all the usual suspects. I need a scan, I need an injection, how long is it going to take better? I've heard it's going to take forever. At the end of that, I would then come into the session and answer any questions which had been raised, common themes that had been brought up, and took the opportunity then to talk to people about general lifestyle and exercise and kind of piggyback on some of the wider messages we wanted to pass over. And then we begin our rehab. We went a bit Joe Wicks. We created an exercise along with me for the shoulder. That was quite interesting. And we also had a patient information leaflet, a progressive kind of rehab program, so almost like a smorgasbord of exercise. Choose what you want to do them if you can, if they're sore, ease up, etc. Importantly, patients had our contact details as well, so they could contact us if they had any issues. I say it was Mark's, and Mark would filter people to myself. Then at 4 weeks and kind of 10 to 12 weeks, we would have a catch up with the patients, 60 minutes at a time, totally patient-led. You know, we had no agenda, we just, over to you guys, what do you want to talk about? And what was great was to see people talking to each other about what they were doing, little hints and tips on how to do their exercises. We would do a range of motion check again, and then in the last session, we would hand out a feedback questionnaire and ask the patients, do you feel ready now to continue your rehab journey? And on balance, most people were quite happy to go off. As with one-to-one care, though, there was the odd patient that maybe needed a bit more support, and it was quite easy to then bring them in to see us. So, as a service, we wanted to evaluate this. It was quite convenient. I was doing my dissertation at UCLan at the time, so I did this for my MSc. And we took a convenient sample of the first 6 months of groups. So that was about 4 cohorts. As you can see, we had 31 patients attend, and average age of about 54, slightly more females than males, which I would say is representative of this client group. We did have 1 DNA. We had 2 people unable to attend, which was due to technology constraints, which has been talked about, hasn't it, about digital inclusion. And we had 2 patients that we deemed were stiff. We didn't like their level of external rotation, so we moved them into our stiff shoulder pathway. So we went ahead and evaluated the baseline measures. So we can all read, can't we? We can see there that we had looked at pain, movement, MSK Health Questionnaire, and Quick Dash. So we had an improvement post group, less improvement in external rotation, but again, I wouldn't expect to see someone with atraumatic cuff pain to have a huge loss of external rotation. Focusing on pain, MSK Health Questionnaire, and Quick Dash, we saw that the improvements were beyond the minimal and clinically important difference set out in the literature, so we were quite happy with that. And as you can see, the results were significant when we looked at a statistical analysis, with the exception of the external rotation. So as a team, we were quite happy to say it was an effective way to manage patients, group consultation, with atraumatic shoulder pain. But remember, we're not saying it's more effective than one-to-one care, just that it's effective. We then looked at efficiencies. So to do this, we looked at our 2019 data. So we looked at October. Anyone that came in with a read code of atraumatic shoulder pain was around 124, I think, although there were several left unchecked, so that could have been more. But on average, they had 2 hours, 30 minutes direct clinical contact time, which was about an initial appointment and 3 follow-ups. Most of our patients at first kind of point of contact see a band 6 therapist. So for a salary cost analysis, we looked at using a band 6 wage, and that equated to approximately £42.42. We did the same sort of analysis with the group consult patients, and they had an hour clinical contact time. But remember, in reality, they had 3.5 hours contact time. It was just shared. And that was at a cost of £16.79. So that was myself and Mark's salary time. So as you can see, significant sort of savings on time, 90 minutes and £25 a patient. I'm not a mathematician, but I did have a little look at it yesterday. And it's about £38,000 worth of savings if we scale that up across a year within our service, which is funds we could divert into other areas of our patients. Most importantly, what did our patients think? And now this is the bit I was a bit concerned about. What did the patients think of the sessions? But as you can see, people were quite happy. We had about a 42% response rate, which I thought was all right. And the sessions were rated 7.9 out of 10. Over 80% would recommend the sessions to their friends or family. And people felt better able to manage their conditions, which was that self-efficacy. What we're looking at was we're looking at not fixing your shoulder, we're looking at helping you help your own shoulder problem. We had some free text feedback as well. And when we analysed that, the common theme of peer support came out. Good to compare my problem with people who suffer the same condition. It was good to hear other people's experiences. And it felt reassuring to know that you weren't alone. And in fact, I think it was that respondent who, at the end of the session, when everyone dialed off, just had a flood of tears talking to myself and Mark about, she just thought she was the only person in the world with this horrible pain and was now massively relieved that she wasn't alone. So I've spoken enough now. I need a quick drink. So what I'm going to do is I'm going to just share one of our patient voices with you. So if you do want to hear more about group consultations, I would recommend the website. There's lots of sort of testimony from clinicians and therapists alike. But I'm going to be quiet now and I'm just going to pass you over to one of our patients.
But from having telephone consultation with my GP, and I was seen pretty quickly and contacted the TIMS people for physio, and I was seen pretty quickly. And there were 6 or 7 of us in the group, and I expected that we would all be jumping about doing exercises, and was very pleasantly surprised to find that that didn't happen. We each had a measure of what we could do, a couple of seconds with this one and that one, and as it progressed, as the months went on, you could see improvement in more or less everybody. What I enjoyed about it was the fact that often another patient would prompt and remind myself that I was going to ask that question. You know, when you go to the doctors and you might write a list of things that you want to ask because you forget. Well, I thought that, and this did happen a couple of times. One, I think I did tell Alison, I was unable to fasten my bra. I was unable to loosen it, and I was unable to fasten it. But another lady brought that up and I says, oh yes, I can't do that either. So in the group setting, which was very relaxed, it enabled me to think of things that I would normally have written down and said to the doctor. That's what I'm trying to say. It was very friendly. Both the physios were extremely professional, and I just enjoyed the whole experience of the first one and looked forward to the next one. We came away with a set of exercises, and then we were measured each time through, you know, a little bit of exercise from each of us, and that's how it went on. I found it a very pleasant experience. I definitely felt listened to. I didn't feel as if anybody was clock watching. Yes, we all had the same problem. We all have upper shoulder problems. I think it was called an upper limb group. And I definitely felt listened to, and actually learned a lot about the condition and about why that horrible pain was there. They were able to tell me all about it. And I do feel as if I got more in each session than I would have gotten on a one-to-one. I was also told that I would not have been seen until the other side of Christmas had I waited for a one-to-one session. I also felt very safe because I was in my own home, not having to travel out to a clinical setting. So that was also very, very comforting. And we had a little bit of a laugh as well, which was very nice.
So I don't really need to say much more than that, do I? She's summarised it quite nicely. But again, that kind of peer support is really what I think the benefit of group consultation is, as well as the time as well. So take-home messages. I'll finish up now and let Jane have a turn. So group consultations can improve sort of patient outcomes and experience, but more research is needed in MSK. And that's kind of going back to what Fraser was saying at the start. And that was the message born from my literature review, really. If you look at blood pressure, diabetes, lifestyle management, group consults are widely used. They're just not adopted as such in MSK. And group consultations from our review were seen to be an effective way to manage atrial shoulder pain and a more efficient way to manage them. But they're a bit like Marmite, I will say that. And this is from a staff point of view, as well as a patient point of view. You'll either love them or you won't, but you won't know unless you give it a try. So I'm just going to leave you with a question. You know, could group consultations be used in your clinical area to improve your patient experience, but also help you meet your capacity demands? Thank you.
Thanks so much, John Paul. So let me tell you what would happen in a lifestyle medicine conference. After each speaker, you'd actually stand up and applaud above your heads. And that would be, A, because the speakers are so amazing, but secondly, because it gives you another blood flow, bit of exercise. I think maybe you should do that in the physio conferences too. I'm just saying. So delighted to pass on. We're not going to take questions now, but please do form your questions, write them down, make a note in your phone. We want a flood of questions because we're going to give you all the answers. More questions, more answers. We're in a group consultation. So, next speaker, I'm going to hand over to Jane Ashbrook. She's an upper limb physiotherapist in Warrington and Halton. Can't even say it. But she's also a volleyball coach. So please welcome Jane, who's going to tell us about her experience.
Hi everyone, so I'm Jane. I'm an upper limb physio specialist at Warrington and Halton. And today we're going to talk about the development of group consultations in our service. So for some background, and I'm not expecting you to be able to read that slide particularly, but Halton Hospital sits in one of the highest areas of multiple deprivation in the UK. So that means 40% of our population are income deprived. The red dots on this represent areas in which we perform worse than our regional neighbours or the rest of England, so such as residents in bad or very bad health, residents with long-term illness or disability, and the percentage of residents with no qualifications. Interestingly, the only thing that we perform well at is our overall happiness rating. So I'll leave that with you. I don't know why that is. But apparently the people who live in Halton are happy. Okay. But it has been shown that one of the most important factors contributing to serially missing hospital appointments or healthcare appointments is living with high levels of socioeconomic deprivation. And there's been a lot of discussion, hasn't there, about health inequalities and how we try and improve that for our populations. Okay, so one of the problems that we have is we have a long waiting list and we have high DNA rates. We have really high levels of referrals to musculoskeletal services, and our service provides a one-size-fits-all traditional MSK outpatient. So you get referred in, you sit on a waiting, or you get triage, you sit on a waiting list, you get sent an appointment. If you don't attend the appointment, we keep you on record for 2 weeks and then we discharge you if you haven't made any effort to contact us. And like I said, we have a long waiting list, high DNA rate. What we do know is that the patients who are likely to not turn up and then not contact us are probably the ones that potentially have the most need or are suffering the most health inequalities, and maybe their musculoskeletal health is not high on their list of priorities. They might be thinking more about how they're going to pay the bills or feed the kids or get to work or all those sorts of things. So really, we shouldn't be discriminating against those people because they don't want to access services in the way that we deliver them. So we wanted to try and implement a number of initiatives to see, well, can we do something different that might, one, reduce the length of time of our waiting lists, or two, provide a service in a different way that might appeal to different people. So there's a list of things that we tried. I think writing to patients on the waiting list to ask them to opt in, I'm not comfortable with that. I think that's not the way to address health inequalities, because obviously we're doing the same thing again, aren't we? We're targeting people who live in socially deprived areas that are less likely to then phone up and opt in. So we wanted to try group consultations because we felt like it seemed like an appropriate way to manage people, like JP said, with similar health conditions. So as a physiotherapist, you might be giving the same information over and over again, or very similar, and advising people similar things. So what if we get these people in an environment that maybe is more supportive to help manage their conditions together? Okay, so we started group consultations virtually, and we did sessions for upper limb, lower limb and spinal. We went for the more broad approach. So I just said anyone who's been referred by a GP with chronic shoulder pain can be invited to a group consultation. And we did the same for spine. For lower limb, we focused on patients who had degenerative meniscal tears or osteoarthritis of the hip or knee. And the reason for that was that we used the Escape Pain programme in our region, and it is really successful in helping to manage people with osteoarthritis. But those patients have to have a one-to-one physiotherapy assessment first, and then they get referred to the Escape Pain pathway. So group consultations felt like a really good way to get all of those people in one room together to have their initial consultation as a group. And then from there, we sort of filter out who's suitable for the Escape Pain programme and who isn't. So unfortunately, with our virtual group consultations, we still had a really high level of patients' DNA. We had quite a lot of people that phoned the department to say they were actually fine and they no longer needed an appointment. But even so, on the days of the group consultations, there was quite a high number of people that didn't attend. Those who did attend, though, had a really good experience. The physiotherapists that were delivering the programme enjoyed it, and the patients that attended did have a good experience. We have subsequently done some face-to-face group consultations instead of virtual, and we have actually found that engagement with that has been a lot better. We've had much more numbers of people attending. However, the outcomes were same, it's just that the numbers were bigger. So, what were the challenges? So we contacted all of the patients that didn't attend. We just contacted them over the phone to ask them, were there any reasons for their non-attendance? Is there anything else that we could do to support them to attend? Or rather than just saying, well, DNA, if you don't contact us, we'll discharge you, is there another kind of form of assessment that would be more appropriate for you? We couldn't contact everybody, just because they didn't answer the phone or whatever. But actually the reasons for non-attendance were multifactorial. So it's kind of difficult to say, if I did it again, I would do it this way, because everybody had lots of reasons why they didn't attend. So the reasons. All of the people, all of the particularly females over 70 all said to me the same thing. Now, when we started this, I thought, I don't want to discriminate against anyone because of age, gender, demographic, whatever. So we just invited everybody who was on the waiting list with a chronic shoulder problem to attend. All of the females over 70 said, I can't do virtual. I either haven't got a smartphone, I don't have Wi-Fi, I don't know how to work the computer. Some people said that maybe if my husband was in, he would have been able to help me, but the majority of people of that age range just did not want to engage, or more that they couldn't engage. I know that's not the same as JP's circumstances, but that was what the patients told me. Some people didn't want to do anything in a group. They weren't bothered about whether it was online or face-to-face. They just didn't like being in a group. Some people didn't mind being in a group. They quite liked being in a group, but they didn't want to do it virtual. One lady said to me, I've done all that in COVID. I hated doing them WhatsApp messages with my family and quizzes and all that sort of stuff online. I hated it. I never want to go online to do anything like that again in my life, but I'll come to a group in the hospital because I feel comfortable doing that. One of the main issues that we had as well was patients trying to navigate the automated hospital IT services. So people being sent the wrong letter that was attached to the wrong clinic, or we had a whole virtual group consultation where everybody got a letter with a link to attend anywhere, and then 2 days before their appointment got an automatic text message from the hospital system telling them to come to the department. But I'd asked them to switch that off, and they couldn't switch it off, so I didn't know that was going to happen. And then we had a whole influx of people that turn up in department. I was somewhere else online, and they didn't have time to get home. So, it's just sometimes it's those little things. I think I'm trying to share with you today what maybe didn't go so well for me, so that when you go away and you do this yourself, you'll be able to learn from my mistakes. Some people just misread the letter, misinterpreted what the letter meant, and thought it meant that someone would phone them. So they didn't really understand what that link thing meant on the letter, so they were sat at home waiting for a phone call. What else? Some people were like, oh, was that today? I forgot. Oh, I was on nights, I fell asleep. So, lots of different things like that. Some people were like, oh, yeah, I'm not really interested in doing that. I don't really want to do that. Or some people were, yeah, my problem's resolved now. I don't think I need physio anymore. But there was a study that I've put up there, and it is in the references by Ellis et al. From 2017, and they found really similar reasons for lack of engagement. So most of it was IT issues and people struggling to navigate IT systems. Sometimes it was just lack of confidence to maybe engage in a group environment, or lack of confidence to do something online that they've not done before. And then a vast majority of people just were, not a vast majority, but there were a big group of people that just weren't interested in engaging. So why didn't we run more events? So actually over a period of, I don't know, probably 6 months, Alison, maybe, we probably ran about 5 or 6 events. And I think we could have ran more, but the main reasons why we couldn't were administration challenges within the hospital infrastructure. So that is attaching the right letters, getting IT to attach the right letters to Lorenzo, so the right patients from the right clinic get the right letters, then people being attached to the right clinic, all those sorts of things that you come across in an NHS setting. The other thing that didn't help is our hospital is transitioning from one IT system to another IT system, and there's about 2 people in the whole of Warrington Hospital Trust that work in IT. So me going, please will you attach this letter to this clinic so these patients get that letter? They were like, yeah, Jane, that's really far down on our list of priorities. We're transferring a whole hospital system. And in a way, I didn't really engage with them enough before I embarked on this process. So in hindsight, that's another thing that you can learn from what I didn't do. What else? And then staff turnover and staff sickness as well. So, you know, it is a different skill set from maybe what you're used to doing in your one-to-one physiotherapy assessment. So you need someone to act as a facilitator and someone to act as a clinician. We were really lucky in that when we were embarking on this process, we did have lots of support from Alison and the team at Group Consultations, who worked as the facilitators, did some training with our members of staff. But as you know, in outpatient department, we have lots of turnover of staff that are rotational. We don't have very many static members of staff in our team. And then, you know, people go off sick, or there's a service need somewhere else. So it can be really challenging. Where are we? But there were lots of success stories. So we had, there was a couple of our group consultations where we had about 10 patients. 5 were referred directly to the shoulder class. So that was quite a common thing from our upper limb. We do have a couple of shoulder classes where we look at you know, developing people's pain self-efficacy and confidence to exercise, as well as improving their cardiovascular fitness and strength. And we have a poster at number 96, I think it is. So if you want to have a look at that, they're the results of that. And we also try and engage with our community health improvement team as well, so we can directly refer into them. So some patients that need that little bit more support go to the shoulder class and then to the community health improvement team. But from the group consultation, we did refer a number of patients directly to the community health improvement team. The patients with hip and knee osteoarthritis, a large number of them went directly to the Escape Pain programme. Some went, again, directly to the health improvement team. We had a number of patients that were quite happy with the information that they got from the group consultation, and they felt that that was enough to enable them to go and self-manage their condition. So they were quite happy to be discharged and not seen again. Some patients wanted to do that PIFU thing, so they were like, well, I am really happy, but I just want you to keep me on your books for another couple of months, just in case things, you know, don't continue to progress. And only 2 out of the initial 20 patients seen virtually did require a one-to-one follow-up. And that was either because they felt like they just needed to be seen and they weren't happy with the group situation. And one was because the patient, when we actually had them in there, it was a cervical, more of a cervical kind of radicular pain really, rather than specifically the shoulder. Okay. So the patient feedback. So this is some of the comments that patients made to us. So everything in orange is a kind of reason why they didn't engage. So 2 letters, and it was really confusing. So and this again, you know, we had a member of the admin team who misunderstood which letter was meant to be associated with which clinic, so sent the wrong letter, then the next letter. And then it was a bit confusing about the link, about not liking the group setting. And, you know, the information that the patients get, it does say if you don't want to attend in a group, then you can contact us and we'll, you know, book you a different appointment. But again, you know, the onus is then on the person to contact to decide whether they want to come back or not. But the positive things far outweighed the negatives, really. So a lot of people felt supported and they felt listened to, really similar to what John Paul's experiences were. They felt that the information given in the session was really helpful. And they did like the idea that they weren't alone, that there was other people in there that had similar symptoms to them, and they kind of shared their own self-management and gave each other ideas. And somehow that was really powerful because, you know, we can give information, but coming from somebody else with a similar problem, I think kind of reinforces that's a good thing to do. And the people who attended virtually really liked the fact that they didn't have to travel into the hospital, and they liked that convenience. Okay, so this is Gary, who's one of the physiotherapists that works with me. He's the lower limb specialist at Warrington and Halton. So I just wanted to share Gary's thoughts on group consultations. So I'm going to hopefully click.
I really enjoyed the group consultation process, especially in a virtual capacity. I feel like it has huge benefits to both us as clinicians and as a service provider, as well as the patients. Our group demographic was osteoarthritis of the hip and the knee predominantly, and the fact that we could have a large number of patients being delivered the same message on a large scale was really, really positive. The feedback from the patients was the fact that they really enjoyed the interactive nature of the session, the reassurance that came from these sessions, not only from the clinician, but other patients with similar ailments. They liked the fact that they could share positive and negative outcomes that they've had so far, things that worked well for them and things that didn't. That shared community and that shared ownership, I found was really positive. I have only done this so far in a virtual capacity, and I'm looking forward to trying this in a face-to-face capacity. There's so many benefits that I feel like can come from this, both for a service user and a service provider alike. I'm looking forward to seeing the results.
Thanks, Gary. Okay, so 2 final slides, really. I think the first thing to reflect on for me was this was a much bigger culture change than I was expecting. So for staff members as well as for patients. So for some context, in COVID, I ran taught on a physiotherapy program, pretty much fully online. So I'm so used to doing stuff on Microsoft Teams and Zoom or whatever that it's second nature to me. And what really surprised me was some of my colleagues and peers who are like 10, 15, 20 years younger than me don't have that same kind of confidence to use Teams and present on Teams and, you know, just those little bits and bobs like that. And then also, obviously, a lot of patients found that challenging as well. I think the administrative challenges to try and get through to the admin team to understand what we were trying to do that was different. It wasn't just, you know, thinking of it like a shoulder class or a knee class or whatever. It's different. It's an initial consultation, but done in a group that then let us streamline our patients to kind of the care that they needed in a better way, I suppose. We did do some follow-up consultations virtually for a couple of patients that just wanted to check in with us a few kind of weeks or months down the line. That went quite well. But actually what we found was most people, we could signpost them to the next kind of stage of the service really well. I think I like to split things up into what went well and even better if. So I'm just going to share that with you. What went well is that the people who engaged either virtually or face-to-face really enjoyed it. They found the information given and the opportunity to engage with other people with similar conditions was really beneficial. The patients who engaged virtually loved the fact that they could do it from their house, but we just had quite poor engagement with the virtual compared to the face-to-face. The even better if, and I feel a bit embarrassed that I'm saying this, that I didn't do it to start with, but I didn't really engage with the patients first to actually find out what they wanted, like I have since. And you might be thinking, well, what an idiot, why didn't you just ask people? But we kind of just went ahead with it because we thought we've got this massive list, we need to do something about trying to engage with these people. So I would definitely engage with the patients first, particularly around virtual versus face-to-face, but in the first face-to-face as well, it's thinking about, well, where could we do this? So can we take this into the community? We've got a local shopping centre where there's like a little community hub. So we're thinking next time we could maybe do some face-to-face sessions there, or community centres, or in the local sports centre. So it's speaking to patients to see what they want. I think the biggest thing as well is the letter and information that goes out to patients is getting some patient input on how that's worded, because a lot of people came back to me and said, oh, it was confusing, I didn't really know, you know, what you meant by clicking on a link or the phone, you know. So I think getting patients' involvement in how that letter's worded and what the information says would be really important. The admin team as well, to facilitate understanding of what we're trying to achieve, to try and make those administrative processes a bit more streamlined. Every page I've got written down hospital IT systems. But, you know, I think navigating that can be really challenging. And then we haven't invited over 70s to virtual consultations, although I had a discussion with you before about maybe, you know, people who are struggling to engage virtually, maybe we need to invite them with a family member. So, you know, sometimes a family member might come to a face-to-face appointment with somebody, well, there's no reason why they can't attend online as well to support them to be able to access that content. And then the other thing I'm thinking is whereabouts in the patient pathway. So we've done this with GP referrals from primary care, but I also sit in orthopaedics, and at the moment there's a 9-month wait to see an orthopaedic surgeon if you've got an upper limb problem. And a lot of people that are waiting on that waiting list are doing nothing for that 8 to 9 months because they think, well, when I see the surgeon, then they'll offer me an operation and then I'll be fine. you know what, 80% of them won't be offered an operation. And actually there's a missed opportunity while they've been waiting that they could have been doing something different. So, last slide, take-home message, I've said this already. Engage patients right at the early stage to understand their preferences and how best to deliver information to them. Find a friend in the IT department. Once I'd done that, this whole process was much easier. And also persevere, like it's been quite challenging for us. Is that to do with the demographic of where we were or how we currently deliver services? And this has been quite a big culture change, but the benefits are potentially significant. So I know I haven't given you much by way of statistics, but our manager the other day said he had just sort of worked out that for one 90-minute group consultation, for every 10 patients we see, essentially I think that frees up something like 6.5 hours or more of new patient one-to-one face-to-face appointments to be there for the people who need them. And even if one or two from the group end up having a one-to-one face-to-face consultation, it's still much more efficient in delivering that message. There you go. Thank you.
Wonderful. So we've got some time for some questions now. So while you are thinking about your questions, and obviously we've got Jane's references there as well, I've got a question for Jane. So we talked earlier about lots of people saying, oh, I don't need an appointment anymore. How many people came back with that message? Because that's actually telling you, that wipes them off the waiting list. So that's quite
I know, and I annoyingly, I don't have the exact number.
Okay.
But I will go back
estimate.
and look at that. But I would
5%,
say
10%?
Yeah, maybe 5.
Yeah.
Maybe 5. So yeah, so at least there has been engagement with those people that maybe wouldn't have ordinarily engaged.
Wonderful. Because what we see long term when we were running our groups for a 12-year period was 40% of the workload was going through the groups, the arthritis groups, but that left lots more space. So it doesn't actually matter for an individual whether they attend the group or not. It still creates space for them. The question over there at the back. Introduce yourself and what's your question?
Hi there, thanks for that. My name is Matthew. I'm an MSK Advanced Practitioner, Commissioner and Clinical Director. So my question, well, I'm going to try not to end on a negative. I want to end the conference on a positive. But I'm feeling a bit disillusioned and a little bit disappointed about where this is potentially going to take the future of our profession. What I haven't heard, I've heard that some of my takeaway messages from the conversations today is that group consultations can be a great engagement exercise in terms of delivering quite generic and quite generalized information and generalized exercise advice. There's a question there about who needs this, what skill and what expertise is needed to deliver that. Technical instructors can deliver that type of generalized advice, generalized exercise prescription. And what I haven't heard is where is the space for the expert sort of clinical reasoning around personalized rehab programs that physiotherapists are really well placed to deliver. So how...
Thanks for your question. I'm going to take that first to John Paul, or have you got a follow-up question afterwards?
No, the question was, just to summarize, was is there still space...
Where's the role for the expert?
Is there still space for expert clinical reasoning and expert provision of rehabilitation within this model of care?
Well, the simple answer is yes, but let's see how John Paul wants to address it.
It's a really good question, thank you. So, I see this as almost like a supported self-care. So, in my sort of simple mind, I see MSK as sort of a bottle of milk. So we were dealing with the milk, the creams rising to the top. So those patients that need that individualised care, it frees capacity and services then to take them in and have more time sort of with them. So as I alluded to, there was a few people there that kind of, it wasn't working for them, so they were stiff. So we moved them out there and he did one-to-one care. Evidently, some of them it wasn't working for. They asked to come in and see us. But by shifting the patients that were able to be managed, supported to self-management in those sessions, it freed us up to see those patients, if that makes sense. So it's not a replacement model as such. As we've alluded to there, it allows to free up more clinical time for the expert to do what an expert needs to do. I didn't need to spend a whole afternoon telling people not to worry about their pain and how to kind of self-manage. I maybe needed to spend a bit longer with a couple of people and took it a bit more further, if that makes sense.
So what I would say from my experience is, and I'm obviously looking after people who have inflammatory arthritis as well as, regional pain and maybe fibromyalgia too, is that actually you can deliver that expertise. So what's needed in terms of clinical skills is the same clinical skills you have usually, and it's how you apply them. So we can treat to target for inflammation. We can get everybody to do a Phelan's test to look for evidence of carpal tunnel and refer appropriately. So we can do all the things you need to in a group. And there's also then permission for them to have a one-to-one discussion at the end. So it's all about how it's structured and facilitated. Okay, I've got a couple more questions we want to take, and then we're going to move on. So is there another question down here?
Hi there, Jamie Watson. I work in an integrated musculoskeletal service, and community pain management is really my area. So I'm fully on board with kind of group consults. In terms of delivering kind of treatment, I think what I was interested here is that for the initial consult was a group consult, and I'm just wondering around asking kind of sensitive questions. If we're thinking spinal pain, red flags, bladder and bowel, sexual function, and I wonder if you might just expand on how if those types of questions are asked in a group, and how that conversation is managed within that group environment, particularly if then someone starts to say things that are pricking your ears up and raising the alarm. Can you speak more about how that's managed?
Jane, are you happy to pick this one up?
Yeah, I can pick that. That was one of the main concerns we had when we were trying to progress with group consultations. Now, I manage patients with shoulder pain, so I can't really, so no one's asked me about cord recliner type symptoms. But however, I do have a slide in the group consultation with things that I would be a little bit concerned about, that we share with people, and I just, explain a couple of reasons why I would be concerned about that. And when we do our kind of one-to-ones with the person within the group consultation, they can bring that up if they want to. Obviously, some people aren't going to want to bring that up in front of everybody else, so we always give them the option to kind of maybe ask us at the end, or we check in with everybody at the end as well. So, they all do a confidentiality agreement thing at the beginning as well. So, it's meant to be like a safe environment so people can share information, but they do have that ability to ask the question at the end if they want to as well.
So we've done a similar thing in our group. So I literally had a patient who had a lot of weight loss, and we as a group discussed red flags, night sweats, weight loss, unintentional weight loss, sweats. And these are worrying features you're looking at, whether you've found any lumps or bumps. Have you checked your breasts if you're a woman? Are you checking your testes if you're a man? There's lots of important health messages you get across. This particular chap, we sent him down for a chest x-ray. Well, his whole lung had gone. He had a bronchial carcinoma, okay? Picked up in the group. And of course, we triaged him straight away. I rang the chest team. They organised a CT. So I have to say, that gave him, because I was seeing him more regularly. A lot of my follow-up patients don't get seen every month when they're active. They get seen 3 to 6 months if we're lucky. So actually having better access, better advice, and that, I think this addresses your point as well, Matthew, is the bottom line is, if we're not seeing people, we aren't looking after them. And we do have an opportunity in a group setting to do much better. Other questions?
Yep, thanks. I've got a question from an online delegate today. Has anyone experience of delivering comprehensive geriatric assessment using group consultation?
I'm going to take that one, because you remember that slide I was alluding to the multimorbidity. That was Scott et al., 2004. So that was the cooperative healthcare clinic model. So that was looking after the very elderly with multimorbidity, and all of the outcomes were better. Obviously, not everybody likes looking after elderly people because they can't hear very well. They sometimes can't think very well. But I've got colleagues who absolutely love care in that setting, and groups can be very effective. But they have the same proviso. If they can't hear so well, then they need the person who's got the hearing to be with them, to help them in the group. And that can work virtually and in person. But we saw the outcomes: lower incontinence, lower drugs, lower hospital admissions. So you really can look after the elderly very effectively in this setting. And it's proactive, because you end up getting them to do the exercises and getting them to keep the weight down and looking after their whole health, not just a limited aspect of it. And because it's social, you avoid the isolation. which is the thing that's going to allow their dementia to advance much more quickly. Not generalizing, but saying, obviously, these problems are all much more common in the elderly age group. Another
Hello,
question?
I'm Linda Brown. I'm a retired paediatric physio, so I'm coming at this from the other end. It's been around for an awful long time. I was running group assessments in the 70s. And it is really good with the children because you've got the parents there. And the key thing about it, particularly for that age group, is you can make it fun. And you can make all of it fun, even for your older patients. There's always that fun element that it's quite important that people are really enjoying it and connecting with what is going on. It's not a question, it's a statement.
Thank you so much. So we shouldn't be forgetting that this has been established and this is fun. So thanks for reminding us of that. What we saw was good evidence for patient satisfaction, good evidence for staff satisfaction. We've heard about the education. We've heard about the care delivery. Now I'm just going to hand on to our next speaker, who's going to tell us a little bit more about the model, and then hopefully we'll have time for a few questions at the end as well. It's my great pleasure to introduce Alison Manson, who's the lead trainer for Group Consultations Limited, and she's an inspiration.
Gosh, live up to that. I'm going to try and bring it to life for you now. I think it's great to hear people's experiences, and we particularly wanted to talk about some of the hurdles that you face and how to overcome them, but I want to kind of go back a little bit and bring it a little bit more to life for you. So if you think about a group consultation having 8 touch points, so you work with a facilitator, so as the clinician, physiotherapist, nurse, doctor, whoever is the right person to be in that room, you're not there for the whole time. You heard JP saying on screen he was there, but he was off screen. So actually that cuts down the time. What tends to happen in the early days is if you're doing it virtually, the clinician sits in with the camera off just to learn about the process. But actually as time goes on, as the clinician, you don't have to join till about 20 minutes into the session. So what happens when you're not there as the clinician? Well, the facilitator sets the scene, they make the patients feel comfortable, they talk about confidentiality and what that means to patients, and more importantly, they tell patients what is going to happen and when, because the likelihood is it's the first time a patient has been to a group consultation or a consultation like that. And, as Jane said, there was a lot of confusion with patients. You have to keep this really simple. And sometimes you'll get patients walking in, despite the letter that outlines that it's a group, there'll be other people there, and they go, oh, I didn't realise this was going to be a group. So you have to explain to them, it is, but it's about you getting a one-to-one consultation in this group, which is why we do X, Y, and Z. So the first 2 or 3 points are led by the facilitator, who then brings the clinician into the room. The clinician does some upfront stuff, then they transition into their one-to-ones, where you're getting more into the personalised care. You have information about that patient, either from the case notes or from an About You survey, and we have a results board which outlines some of the key things that you would want to discuss with that patient, which is shown to everyone. And I'll show you an example of this in a minute. So, as I say, the clinician does the upfront, the general information, the education part, before transitioning and going round the room and checking in with everybody individually, with everybody else listening in and learning. And that saves the need for repetition of key messages, as you can imagine. Once the physiotherapist has done that, they leave the room, and the facilitator who has been there for that whole time, supporting the clinician to do their best work by managing any group dynamics, takes over and gets patients to think about, well, based on what you've learnt today and your consultation, what are you going to do differently moving forward? And that's a really important thing, because in a group, it really opens up discussion and people start to support each other. Often when we do it face-to-face, people buddy up. So they may go to an exercise class together, they may go swimming together. So it's good from that point of view. But the most important thing to remember is one-to-one care is delivered within a group consultation. All of the other stuff is lovely and it's great, and it's my background is in personalised care. It is, it's my passion. But the world we're living in today is about how can we do more with less in a good way that still delivers high quality care. So I'm going to show you this little short video that walks you through what this looks like in a virtual group consultation.
Virtual group consultations look much the same as a face-to-face group consultation session, but delivered through a virtual platform. Let me walk you through a high-level flow now to help bring this more to life. Patients log on through your platform of choice. A link should be sent directly to them, and they will have received pre-meeting guidance and confidentiality forms. The facilitator sets the scene, navigates everyone around the platform, for example, using the mute button, the hands up function, etc. Then moving on to some ground rules on etiquette and the flow of the session, so everyone taking part knows what to expect and when, and gets everyone to introduce themselves. Then, the facilitator introduces the virtual results or discussion board and explains to the group how the clinician will use this. The facilitator then opens up to the group and gathers in questions from each patient for the clinician. Then the clinician joins the session and the facilitator shares with them any common themes that the group have been discussing. That means that the clinician can then cover these key themes up front with the whole group, preventing the need for repetition of key themes and advice. The clinician then checks in with each of the patients individually, carrying out the one-to-one consultations, with the rest of the group listening in and learning. It's then that the clinician hands back to the facilitator and leaves the session. The facilitator then works with the patients, asking them to reflect on what they've heard and any advice that they've been given, and set some small goals and actions to move forward. The session is then brought to a close by the facilitator, and patients are asked to give feedback. It's at this point that the facilitator can signpost patients to any other social prescribing or community initiatives that members of the group may find useful.
And that's it. It's as simple as that. There are variations in that, of course, but that's the kind of blue, or the gold standard of what a virtual group consultation could look like. And one thing I will say is, what a lot of clinicians that we work with do is they read minds. I don't know, I mean, I've got a clinical background, I've read minds forever, and I'm a woman. And they read the minds of patients and they tell us at the beginning the patients won't like virtual. And some of them do. You've heard some of that today, but you've also heard some of the challenges. But just reach out, give people choice. This is not about replacing all of the work you do. It's about giving patients another way of seeing you and having their consultation. So we've spoke quite a lot. Now I want to play just for the next 28 minutes or so. So I'm going to ask you guys to do something for me. I am going to ask you all to imagine, if I went too back, hold on, yep. I'm going to ask you guys to imagine you're all patients. So for the next 20 minutes, you are patients that have problems with your shoulder. So I'm going to ask you to really use your imagination here and imagine we're not in a room like this. We're in a nice little room and there's maybe 10, 12, 14 of us and we're all round a table or all round a circle. So get yourself into that headspace and I'm just going to walk you through what it feels like. So I want you to think what this would be like for your patients and I'm going to act as the facilitator. So the first thing I'll do is welcome you. Thank you for coming to today's group consultation appointment. It's a little bit different from what appointments that you might have had before, but we know that patients are seen this way, enjoy it because they get to spend longer with their healthcare team and they like being with other patients with similar conditions. What's going to happen today is here, it's up on the wall, it's quite clear. We're going to do some introductions, get to know each other a little bit better. We're going to look at what we call our results board, and I'll share that with you in a second, and it's just got some results that the clinician will use to give you the best advice for you moving forward with your shoulder pain. And then I'm going to get you to think about what you want to talk to the clinician about when they join the session. And that's really important that you've got some time to think about that before they come in. And then, of course, I'll invite Jane into the session. She'll do some upfront stuff, general education with you, and then transition into your one-to-ones, move on into the one-to-one consultations with you, because there will be some general information, but there'll be some things that are absolutely specific to you in your case. before we do that, because we're a group, I'm just going to ask you to all read over this, make sure you're happy with it. We call this understandings. What it means is that we're actually going to adhere to these kind of rules and guidance because this is a group appointment. You've all signed a consent form. Thank you for that. What that means is that we will not repeat anything that we hear outside of this session. You can, of course, talk to your family about your specific information advice that you're given, but this is not conversations that we have in the supermarket or at the school gate. They stay in this room, and thankfully, and thank you all for consenting to that. So no pictures, if we're doing it virtually, no screenshots, recordings, etc. This is an opportunity for a longer appointment. You've got longer to think about what really matters to you and the challenges you're up against, and get Jane to give you really good advice and guidance on that. My job really now is to keep to time so you get as much out of this appointment as you possibly can. And is there anything else that any of you as patients want to add to that? And are we all happy? Just let me see a wee show of hands. Are we all happy to sign up to those? Thank you. And the last thing is that we want to keep this really focused on your shoulder pain today. And we all know what happens when we start talking about health. And we know there's connections there. So if anything comes up with you that falls completely outside of what we're wanting to focus on today, I'll take a wee note of it on what we call a car park. It's not where you park your car. And if we've got time and if this is the right space to do that, we'll come back to it at the end of the session. Okay, so what I want you to do now is, so this is where we would just get people to introduce themselves, but I want you just to chummy up with somebody and introduce yourself as if you're a patient and how long you've lived with your shoulder pain. So do that now. Let me see you speaking. You've been listening for far too long. If you're not sitting with somebody, then turn round or...
Silly things in the gym.
Okay, we would probably give about, we'll go around the room doing that and we would do it individually, but I just want you to notice the change in energy. This is not about me as the clinician coming in and telling you everything I know about shoulder pain. It's about identifying and finding out and you sharing and helping each other. And the reason that we do the introductions pretty much as soon as we can get to them is just to change the energy in the room. It is absolutely firmly putting the patient in the centre. The other reason we do it is that once people have heard their voice, they will contribute more. There is scientific research to back that up. I don't know what it is, but because people often don't like to speak out in a group, or they don't like to stand up here and do something like this, but once they've heard their voice, they become more comfortable. So it literally takes 2 minutes to go around the room and do it, and we train the facilitators in little tips and techniques to do that. So then when everybody has done that, I'll say, so you heard me mention the results board at the beginning of the session. I just want to introduce you to this. There's some headings around the top. You'll notice your name down the side. You'll notice some things that are the same for you and other people in the group today, and some things that are different, some things that are different, I beg your pardon. I'm not going to go into that. Jane will refer back to that when she comes into the session. And this is information that Jane really needs to have to give you the best plan moving forward and to guide you moving forward with your shoulder pain. So have a little look at that. See where your name is. Have a little look along the line and think about, do you understand all of this? Is there some questions around this that you particularly want to ask Jane when she joins the session? So what I want to ask you coming out of role play is, how does that feel, bearing in mind your patients? How does that feel looking at this? Does anybody want to shout anything out? Good, bad, or indifferent? Yep, lady at the top. Okay, so the question was that people have very low level of literacy. Absolutely, and there's a lot on this. So what we usually do is that we train the facilitators to look out for that, to identify that, but also to read through. So I would have said, we would have been in a smaller setting, and I'd have said, we can't see that, or you don't, you've not got your glasses. Do you want me to run through? I'll happily run through what the board says, but I can't give you any advice on that because I'm not the clinician in the room. I'm the facilitator. And that's very much easier to do in a face-to-face session than it is in a virtual session. So what the clinician will do is they talk about it in a little more detail. And we do try to make it baby speak. We try to keep it really simple. It's an ongoing challenge that we have. This isn't very biometrics driven, but if you're doing it for diabetes or renal care, renal transplantation, renal dialysis, it can look really, too much. And a lot of the work that we do in supporting people to get up and running is having discussions around their results board and what they should and shouldn't have on it. But it's there for the patients and it's there for the clinician. It's there for both. Often people will say, oh, patients won't like that. They love it. As a rule, it is the first time ever they've been able to contextualise. You heard GP's patient talk about it. I thought I was the only person. I think Jane mentioned it as well. We hear this all the time. I work in every therapy area you can imagine in health, and we hear it all the time. I thought this was only happening to me. I thought I was the only person that had this pain, this stiffness, this symptom. So we sometimes call it a conversation board. I do some work in cancer, and results has got a really negative link, as you can imagine, for people going through cancer care. So we change it and modify it, but by and large, it's really important to have that in the room. And you're right, that's a busy one. Most of them aren't as busy as that, and I think we even simplified that one when we used it as well. Okay, so you've done that. What I want you to do is look at that now, and again, I want you to pretend you're still patients and have a little chat with the little group you're in about what kind of things do you think you're going to ask when you go in for your pain and when the clinician comes into the room. So again, just a couple of minutes doing that. Go, go. Celebi. Okay, I am rushing through this because my esteemed colleagues all ran over. I just want you to know that. But I just want you to have a little play with this. And this is really important because what patients tell us is they go into an appointment, the ones that plan ahead and can think clearly, write down the things they want to give the clinician. But as clinicians, how many times have you had, it's that when they're walking out the room, they go, oh, and by the way, and you're like, oh God, why did you not just mention that at the beginning? So what this gives is it gives patients a space, the time, the support system to think about what is getting in the way for them. What is the biggest hurdle that they have in managing their shoulder pain? What is the biggest concern? So really, really important to do that. The other thing about this is we then go around and get patients to share with the rest of the group. What questions do you have? We don't do it in pairs. We do it individually to the whole group. It only takes one person to mention something that people might not want to mention. The gentleman earlier mentioned, personal things, erectile dysfunction, you may have pain down below, lumps and bumps. It takes one person to say it, and you always get somebody else or a few other people in the group going, oh, so glad you asked that question, I didn't want to. So the group support each other. So as a patient, you're getting answers to questions that you were too afraid to ask and answers to questions you didn't even know you had. It is a really powerful patient interface, a group consultation. Okay. Then, as a facilitator, I would then invite the clinician. I would say, so the clinician's going to join now, and we'll get into the nitty-gritty of what you're really here to do is to help manage your shoulder pain moving forward. So Jane would come into the room.
Stay here.
You've got, do you want to just do it from there?
Yeah, I'll do it. You can hear me, can't you? So I think the thing is, well, there'll be maybe a little break now so I can discuss with the facilitator what the results board says, or if it's virtual, I might have been listening, do you know what I mean? I might have been present, but not there on the screen. So I know what the questions have been asked by the patients. So we might start with a little bit of education around the shoulder and what problems can happen with the shoulder, but that'll be guided by what the patients have said. So I might answer some of those questions without obviously answering those questions when I'm talking about anatomy. A lot of people have had scans that show tears and they're really concerned about that. So we can bring that into that sort of like a bit of a bespoke education bit. And then we might talk about, well, the most common problems that people with shoulder problems have is either pain or loss of movement. So we talk about, you know, what are people's methods of managing pain. I might give them some advice, or I might kind of throw it out there to the patients to share what their strategies are. But we also talk about the other things that can impact your pain experience, such as, you know, social functioning, being physically active, those sorts of things. So we try and sort of introduce those concepts as well, that it's maybe not just about the shoulder, it's about what else is happening in your life.
So I'm going to fast forward this, and it's Saturday afternoon. I'm guessing you guys want to get out of here at some point. I'm very impressed you're still here on Saturday afternoon. This is just to kind of give you a bit of an overview. So the clinician would do, Jane would do maybe 10, 15 minutes up front, and then, and this is just an example of some of the slides that Jane actually used in our session. And then she would transition into her one-to-one. Jane, do you want to quickly just tell them how you do that and how that feels?
So we'd go around the room really and do a little bit of a range of movement check, and then just check in with each individual person after we've done the rest of it to see what other things are important to them, really. And we maybe touch on some of the ideas that they might have or have had already as they've been in the session of what their next steps might be.
And one of the most common clinical questions that come up to us from clinicians is, how am I going to do all of this in the time I've got? If I've got 10 patients and I've got 45 minutes, that's 4.5 minutes per patient. It's not, because what you don't need to do is continually repeat the same messages. And that's what we do a lot in our one-to-ones. So your first few patients in the one-to-one may take a little bit longer. By the time you get to your 5th, 6th, 7th patient, your consultation is building, so you're drawing back. So what I said to Emma, actually, John, the first 2 things apply to you, but the other thing doesn't, because actually there's a little flag for you in X, Y, and Z. So your consultation does build. And the other thing about this is that every patient leaves feeling they've had an hour of your time, not just maybe that 5, 6, 7 minutes where you were completely talking to them specifically about what it meant for them. Because there's so much, and the gentleman mentioned it earlier, there is so much general information, but don't confuse a group consultation and being a space that you don't get into the nitty-gritty. I do it in renal, I do it in orthopaedics, I do it in rheumatology, I do it in gastroenterology, you name it, as well as the long-term conditions in primary care.
Just one little thing, sorry, that this is the bit where if there's something that doesn't fit with a shoulder problem, or you know, something that you think that maybe they're experiencing some pins and needles, numbness, or you know, something else, this is the bit where you really get to the bottom of those, and then you can, you know, maybe have another conversation with that person or book them in for a one-to-one or whatever, but that's where you maybe pick up the red flaggy type things. Or
and
other
for other clinicians, this would be the bit where they would prescribe as well. So you would prescribe for patients in other conditions where there's more medical kind of focus or more biomedical focus. Okay. Right, I'm not going to do that because we're running a bit short in time now. So then the clinician leaves the session. The patients are still there, the facilitator's still there. When the clinician was doing their bit, as a facilitator, you don't check out. You are there and you're managing the room if you need to. Often you don't, but you're just making sure that things flow, things keep to time, that things are specific, that everybody gets a fair crack of the whip, if you like. Everybody gets an opportunity to talk to the clinician about what matters to them. So that's really important. It's also really important that the clinician leaves, because if they don't, it can all go terribly wrong. And often the clinician will say, I'll just stay till the end. And I'm like, no, because what happens is the patients will then find 100 other things to talk to the clinician about that are not at all relevant to what that appointment is for in that time. So the clinician leaving really indicates to the patients, we're getting near the end of this appointment now. And then what the facilitator does is just works with the group. You saw it in the video, you heard about it in the video, whether it's face-to-face or virtual. I would then go around with you guys and say, okay, so you've had your consultation now, you've had some general education. What one thing are you going to do differently now to manage your shoulder pain moving forward? And again, I would get you to share that with the group, which is incredibly empowering. And also, you might not have a clue what you're going to do, but something else that somebody else is going to do sparks you. And this is where, particularly in the face-to-face space, that people buddy up and they make friends and they go to classes together or they go walking, things that I mean, I've heard some amazing stories over the time, you know, people really cementing friendships and ending up going to walking clubs, walking groups, etc., etc., particularly when we did it virtually as well through COVID. Then we would get to the end of it, and it's really important when you're starting to do this is about change. You've heard that change is not easy, of course it's not, but what is that definition of insanity? If we keep doing what we're doing and expect a different outcome, then really we're kidding ourselves on. So this isn't all streamlined. This is not, you know, you need, and this is why we support teams and organisations to do it. You particularly need operational support and making sure that the admin know what's happening and when and how. But actually, it's really important that you get real-time feedback because you get to this stage and you may have had a bit of a bumpy journey, like Jane spoke about, that the letter went out, we had high DNA, this didn't happen, and you're thinking, what the heck am I doing? Why am I doing this? And this is where you get these nuggets, and this is where the feedback from the patients comes from, and you've seen a lot of that today. This is about delivering quality care that's as good as one-to-one care, and often better. So don't think about this as being substandard care. This is about good quality care being given and received by patients. But you want to hear what they have to say about it, but don't wait till they've walked out the room and send them a form. That's part of a formal evaluation. Just ask them to tell us. So guys, it's great. Build on what you've learnt today. Keep friendships going, share experiences, advice. If you have to come back and see us, then you'll have had that day. If you don't, carry on with the plan that Jane advised you on. What we would really like, because we want to get this right for more patients in this area, if you could just tell us one thing that you enjoyed about today and one thing we could do better moving forward so we completely get this right for the patients in Halton moving forward. Or where are we today? Manchester, moving forward. So that's it really. What I want you to do now before you leave is I want you guys just to go to the person that you've been doing the little exercises with and just for 2 or 3 minutes share what nuggets that you've heard today, the good, the bad and the ugly, and think about, and it might not be group consultations, but what one thing are you going to do differently moving forward with your patients? So over to you guys to finish this off, and then I'll hand over to Fraser. And you, I told you not to do engagement because I thought this would be the engagement where we're asking them what can we do better, what can we, but it's not really good. I know. In our team, we were like, oh, okay. She almost, she quite significant. Well, I did wonder, but I thought there's no way or something, right? She almost looked like she was kind of going to break down.
Wonderful. Loving the energy in the room and the fact that these ideas are sparking. Actually feel the energy. So we've had a whistle-stop tour, and what we've seen is we can get more time with our patients and deliver personalised care. We can use them routinely. We can get rid of backlogs and waiting times if we use them for new patients. We can connect people with similar challenges and get them to understand that they're not alone. Particularly the kids' bowel and bladder service. I mean, the stigma in that room was amazing, the energy, you know, as people saw the relief. There's no need to repeat the key messages. You can support the workforce. I mean, all the speakers today, you can see the joy that delivering care this way. We're actually starting our face-to-face groups again next month, and it's my very favourite part of the week. So it transforms us at a different time where we're all under pressure. This is something we should all be doing if you want to, because it's all about choice. It can be more efficient as long as you do it right. we're looking at access to specialist care, and you can promote lifestyle change, which is very hard to do otherwise, but we need to eat healthily, we need to exercise appropriately. You guys are the experts, and you need to be able to share that experience. So it's the ultimate shared decision-making area, really. If we think about how our pathways should look going forwards, you know, common problems like knee and hip pain, and we've talked about shoulder pain, people waiting for 9 months to see a surgeon. Well, you know that shoulder surgery isn't very good. The outcomes aren't great. They might get rid of some pain, but they never restore the range of movement. And if they have a painful shoulder condition and don't do their exercises, their physiotherapy, they're going to lose range of movement and have a frozen shoulder. So it's essential that we embed this in pathways, wherever there's a big waiting list, whenever there's people who are suffering in pain, so that they understand the drugs aren't very good, but if we see them in a modified escape pain group for the first time, and then triage them into a right pathway, and we've got now very good evidence that inflammation is involved in osteoarthritis, so there are selected people who might end up having a guided hip injection or a knee injection, or possibly some people who might even have methotrexate, so you might have a rheumatologist join your group for 5 or 10 minutes, but the core is going to be delivered by you guys, okay? So if we deliver that efficiently, if we have appropriate intervals of care, if we have a way of them re-entering the pathway, and we can take people who are on the waiting list and they won't need an operation. We know that only 80% of people are going to be better after knee replacement anyway. So the more people we get pain-free and mobile with strengthening and aerobic exercise and weight loss, the better. And fewer heart attacks and strokes, better blood pressure, diabetes in remission. David Unwin's groups have shown us that we can do that at scale. So looking forwards, we need to change the world, and we know the world is going to change for us. We're all battered by IT failures every day, but this can deliver a real experience where you're actually enjoying delivering care and having a different challenging session each time. So hopefully you'll be inspired today and go away and do something. I'm not going to take any more questions for now because we're really running short of time, but we're all going to be here to answer any questions. Please do reach out to us. If you do change your practice to incorporate group consultations, either in a pathway or in your own service, you will never regret it, believe me. Thank you so much for our speakers. And if you could just scan back to Mentimeter for the last few questions.
We've got a little booklet here with some case studies and stuff in it. If you want, just please help yourself. I'll leave them there.
So what do we have to do? Oh, it's supposed to do...
Yeah, there we go.
So if you scan to Mentimeter, what do you think of it now? If anybody's on Mentimeter. Well, that's a definite shift of the curve. So thank you for that. And then how might you use it going forwards? This is the stuff you've just been chatting about in your small groups. So how might you use it going forwards? Feel free to share. For thumb away, for knee away, accessibility treatment. Love it. I mean, this is the thing. It's for common stuff. It's for getting rid of the waiting list. We know that injections are rubbish for thumb away anyway. The important thing is the weight loss. It's the exercises. It might be using topical non-steroidals or capsaicin cream. There's a lot of things that people can talk about and share, things that have helped them. Peer support. The thing is, once you're delivering group care, actually the peer support looks after itself because people start their own peer support groups afterwards. So people become independent and self-managing and self-caring. And this is what we need going forwards. Right. Thank you so much for your active engagement. I'm going to have a last round of applause for all of our speakers and for Alison bringing this all together. And I hope you enjoy the rest of the weekend.